How will it change our jobs? Quite substantially, and it would require quite a bit of discussion. I would propose to you that we will remain in charge, and that's one of the reasons why I prefer AI to refer to augmented intelligence rather than artificial intelligence. That doesn't go through so well in the public. I think AI will substantially change our job. If you can read French, I just wrote a book on this, a small book, for the Academy of Medicine of Belgium. As time is running, I will not go through ChatGPT. I will immediately propose to you that AI will help us in a number of procedures already. So we will have more time for other things. Endotracheal intubation is one of many examples. Clearly, it can be done by a robot. If the robot is clever enough to do a bit more than just apply a standard procedure. As you may know, drones can bring defibrillators to where we are, and that could facilitate CPR. That's not AI. No, the next step is coming. That's robot CPR. So it's not just defibrillation, it's airway management, administration of drugs, in addition to chest massage, of course. So we will just put the robot there and do some other things during CPR, right? Robots will be everywhere, and of course, we will have them available for many tasks. I'd like to emphasize that in the future, thanks to telemedicine, we will no longer have to transfer a patient with acute coronary syndromes from one institution to another. If someone in the smaller institution can insert the catheters, and if a specialist from a larger institution can do the job in the distance. And that's actually what I want to underline at this stage. It is that there will be less doctors around us in the hospital. And as we wrote with Dr. Slutsky and Dr. Gattinoni some time ago now, you never know where the doctors really are when they appear on the screen. So a doctor could control patients in several institutions. For those of us who work in private institutions, this may have some substantial consequences. We no longer have to take our cars or public transportation or bicycles to go from one institution to another. And of course, robots can do everything, including send us these auscultatory sounds. Help in diagnosis, yeah, that's quite straightforward, of course, because when we analyze how we make a diagnosis, we combine clinical features with history, lab test, imaging, etc., and then we try to write down a differential diagnosis. But that's something that an AI system could do for us. It may help us substantially and help us to buy time with less discussions among colleagues and more rapid interventions. We all know that diagnosis can be made quite reliably by AI systems. We know about the melanoma, we know about the mammogram interpretation, but in the ICU, it's also X-ray protocols. We no longer have to go and try to find a radiologist. Even for bedside CT scans, we will have the protocols right there. So, less time spent on this. And MRI is also coming at the bedside. Well, help in treatment will be substantial. When we think about it, and I'm sorry I alluded to that this morning, some of you may have attended that talk, but when we decide which antibiotics to give, we may call the infectious disease specialist, but the infectious disease specialists like us will consider a number of elements to decide which antibiotics to give, at what dose, by what route, etc. And this was described already in 1998 in the New England Journal of Medicine. So we will need less infectious disease specialists, but we will also have less discussions with them. Now, a question that people can often ask is, can AI replace the doctor? Actually, we may imagine that in straightforward cases, like here, the left-hand side, it could be yes. If we have a decreased cardiac output associated with an increased heart rate, decreased CVP oliguria, it's obvious that fluids must be administered there. And we could imagine that we allow the AI system to do it. But in most conditions, the AI system will not really replace the doctor, but perhaps make some proposals, including some proposals in strategies to apply. If we know only that there is a decreased cardiac output, we need to find the reason for this, and this is not really straightforward. It may be hypovolemia, it may be a cardiac problem, it may be an obstruction, like in severe pulmonary embolism. So let's take an example of a patient who has been anuric on CVVH. There is no hemodynamic problem whatsoever. The CVP has increased and the fluid balance has increased in this anuric patient. So we could have an alarm going on, and the system may say, can I increase the ultrafiltration rate? And we could say yes or no. The responsibility will remain on our shoulders. We will remain responsible for the care of the patient. And the industry, of course, is very cautious about that. They don't want to have legal problems if there is an error somewhere. Well, as we know, AI systems are particularly helpful to combine variables. Your digital nutritionist is there on your smartphone. But if I return to endotracheal intubation, when shall we intubate a patient if needed? Not too late, of course. We don't want to wait for the respiratory arrest. Not too early, of course. We don't want to perform an endotracheal intubation if it's not absolutely necessary. But if we think about it, we need to consider a number of variables, and for our human brains, especially for those who are not very experienced, it's not really straightforward. And my colleagues and I, we wrote recently this piece where we said, you know, we asked our other colleagues, when I was at the Surviving Sepsis campaign, I was asking, you know, can we give some guidance for endotracheal intubation? And my colleagues were saying, but Jean-Louis, there is no prospective randomized control trial on it. We still need to give advice without prospective randomized control trial. We need to say, look at gas exchange, look at the neurological status, the PCO2, the hemodynamic status, the muscle function, the possible plans for surgery. Wait a minute. We need to tell people, to advise exactly as when we receive a phone call at the middle of the night from the resident saying, I'm not sure I need to intubate this patient. We would go through this list. Now we can go on and speak about lung management in respiratory failure. How much PEEP should I give to this patient? Ooh, a sufficient amount. Because if it's too low, that's atelectrauma. Ooh, not too much. Otherwise it will be volutrauma. What do you mean? Insufficient versus excessive. And then comes the tidal volume. Of course it's important, but we know today it's not the only thing we need to pay attention to. What about the driving pressure, which is perhaps more important than the plateau pressure. What about the elastance? What about the PEEP level, as I indicated? Let's put everything together. That's what is really timely. Look at power. Oh, power. Yeah, okay. Oh my gosh. Yeah. It's not that easy, is it? Well, the computer can do it for you, hopefully. Yeah, I don't want to do all these calculations. But of course, it can be done. But what I would like to do is to have a system that could turn the knobs, or at least evaluate what I'm doing when I'm turning the knobs. Am I reducing the power? Yes or no? That's becoming very complicated. So AI will be very helpful in this setting. Combining tidal volume, respiratory rate, FiO2, plateau pressure, driving pressure, PEEP. And then from there we will indeed find the proper action. Sufficient? No, it's not sufficient. You must put a hemodynamic component here, because right ventricular dysfunction, as we spoke about this morning, can come into play. So let's be careful about the increase in intrathoracic pressure. We need to put that in the equation. And perhaps, as Antoine Vieira-Baron would say, we need to have a good echocardiographic assessment. So as the late Paolo Pelosi wrote here, there are a number of elements that we should look at and combine, and this will be certainly very much improved with AI. And we could go on with the hemodynamic aspect. We have all these instruments, all these monitoring systems at the bedside, but we would like to know how we could better integrate it. Some people gave up on cardiac output measurement because they feel it's too complicated to put all of this together. Fluid challenge, many people don't do it adequately. It's not so difficult, but an AI system could do it for us. And this is done already now in anesthesia. We spoke about it in another session, but with Dr. Josten, we did quite a few studies on this, showing that anesthetic management could be improved with multiple closed-loop systems and proper management of data. So this becomes quite complicated when you look at all the instruments we can put together to collect this information, and that will help us. Less work in the operating room, and we will apply it in the ICU. Less work in the ICU as well. And the avatar-based patient monitoring will help us not just to decide whether we should give more fluids or not, but also whether we should perhaps use an inotropic agent, blood transfusions, more oxygen, etc. So all of this will be facilitated by AI. We won't have to do the echocardiography ourselves, and certainly not call for a cardiologist. But there will be probes on the thorax, exactly as we can already have an automated measurement of ejection fractions or velocity time integrals. It can be done automatically, and with smaller probes, it's even easier to do it. Help in monitoring. On the floor, because we have to go out of the ICU more and more, there will be better monitoring systems. I'm going very fast now as our time is very limited, but we will have very easy ways to check blood pressure on the floor, to check other simple things using rings on the patients on the floor. Why am I speaking about it? Because we will be able to evaluate these patients earlier and more efficiently. We don't need a general supervision system as it is now in many hospitals. We just need to have the signal appearing on our smartwatch. And so much before the serious alarm could be triggered, there can be an early alarm with early transfer to the ICU. Oh, it's more work to the ICU. You will have more admission. No. That's not true. because actually by admitting patients earlier in the ICU, we can stabilize them earlier so they stay less for shorter periods of time than when they have post-anoxic brain damage, for instance. And so they can occupy a bed for a short time and leave. So it's a more efficient way of managing acutely ill patients. And finally, help in research. I will just touch on that because it's close to my heart. Big data will be another way to conduct research than prospective randomized controlled trials. And one of my fields of interest is blood transfusions, because now the recommendations are based primarily on hemoglobin levels. But that's true outside the ICU in stable patients, but not so much in critically ill patients who are in shock. But it's very difficult to define the other variables we could use than hemoglobin levels. You may have seen 3 days ago in the JAMA this paper showing how we actually transfuse patients in our ICUs. It's a study of 233 ICUs. And they have also difficulties to identify other variables than the hemoglobin concentration. But the hemoglobin concentrations vary quite a bit in our practice. And there is some evidence that blood transfusions could help in anemic patients in shock. So that could be also found in our AI system. So in closing, we will perhaps need somewhat less doctors. But since there is a lack of ICU doctors in many places, this may not really hurt. Let's hope that doctors will still be at the bedside and not just behind computer screens. But the role of the doctor will really change over time because we will have more time to discuss with the patients and the families. And we know that the shifting power will go from doctor to patients and their families. We need to advise them, and they complain that we do not have enough time to talk to them. So we should embrace the future with optimism, but consider that this will really change our environment. And big data will help us in a number of ways. But like Dr. Topol, we should remember that high-performance medicine combines human and artificial intelligence. So humans are still there. We will still need good doctors, good nurses, and we will remain in charge despite the technological developments. Technological developments are there to help to augment our intelligence. Thank you.